residency program training event. We're really excited today for two reasons. Always excited to have Dr. Greenlee present. She's brilliant. She's going to talk about measurement-based care, which is something we're increasingly having to do because payers are expecting it, but it's something we've been really wanting to have implemented across the board for a few years now, because it's a way that we can better evaluate how our clients are doing and track their progress, track dips in progress, and step back, take a look at the treatment plan, just make sure that we're meeting their needs. So Julie is going to provide you with some information about measurement-based care. This may be an opportunity to have a two-part training, in which case we can bring her back later in the year. The other reason we're really excited is because this is the first training that we will actually be offering CEUs through our MBCC CEU number. So all of our live training events going forward, as long as they meet the criteria, will also serve to provide CEs for those of you who are in attendance. So we're excited about that. I see some new faces. I'm always happy to see that. I'm going to go ahead and hand it over to Dr. Greenlee at this point.
Yeah, thanks so much, Debbie. I'm going to share my screen. You'll have access to these slides. We're also recording, so if you are bored and nothing is on Netflix for you, you can always come back and view this again. But please let me know if I start referencing something that I think is on my screen and you don't see it. Let me know that. All right, so as Debbie just mentioned, we have become accredited and are able to offer these CEs, but I have to hold on just to try to keep you here for the next hour. I'm going to tell you how to get that CE at the end of this session. All right, so there's going to be one more step that you'll need to take in Relias in order to get that continuing education credit. So what we're going to attempt.
Can I just add one more thing?
Yeah.
The continuing education credit is for only those who are attending live. So for anybody who's listening to this after the fact, unfortunately, you can only get the CE when you attend live.
That's a good disclaimer. So we're going to be pretty ambitious in our agenda this morning or this afternoon. I'm going to be stuck in the morning, it seems. The first thing that I want to do is I want to level set, ensure that we're all using and conceptualizing of measurement-based care in the same way. So we're going to put a definition to what it is that we're talking about. We'll learn about some of the benefits to both our clients and to us as providers and to the network organizations at ncgCARE as a whole. We're going to look at this paradox that is continuing within our industry that's supported by really recent literature about the underuse of measurement-based care, and just kind of be vulnerable with one another about why that continues to be the case. And then at the end, I've set aside about 15 to 20 minutes for us to actually look at real cases. They've been de-identified, and for us to just look at progress, regression, and what we would do if this was our client that had these particular scores. All right. So we'll dig in, and there's going to be 3 opportunities that I want to hear from you. One of those is coming up fairly soon. So just be ready for that, and I'll launch a quiz. And so there's no wrong answer in this particular setting within Relias. There's no polls, it's just quizzes. So just know that. But what I'd like to know as we get started is, have you in your practice integrated measurement-based care at this point, and what that looks like?
Hey, Julie, I see a couple people in the chat. Someone's typing and they're not on mute, so it's very, very obvious. So if we can have an opportunity to all mute the mics, that'd be really appreciated.
Yeah, perfect. Thanks, Wee.
Thomasina, I think that some of that might be coming from your microphone. You can go ahead and mute yourself. That would be great.
Perfect. So as these results are coming in, we have a really diverse group, which is exactly what I've expected, where we have some that have consistently adopted the use of measurement-based care. I'm interested to hear more about that as this training and our time together this afternoon continues. Others of you that are just exploring it for the first time, maybe it's something you've heard of but haven't implemented. One of the things that we're going to look at is practically how do you do that within our credible and case handler environment. For those of you that don't know, we have Grace Harbor on here, Carolina Outreach, National Counseling Group. So all of our community-based outpatient providers are represented in this learning collaborative this afternoon, which is just really exciting. And then I love the vulnerability of someone that was honest enough to say, I've not yet adopted it, and you need to convince me to do it. And so challenge accepted. I think that I have compelling enough data to share that I'm going to get you there by the end of this hour, but reach out to me if I haven't done that. So the first thing is just for level setting. When we talk about measurement-based care, I want to first just draw out the obvious that this is something that has been done in the physical health space for over a century at this point. We are all used to walking into a doctor's appointment, going to urgent healthcare, the ED, and the very first thing that they do is they take our vitals. And that's because the way that we might experience our symptomology, what our chief complaint is, may be very different than what might be causing us the most life-threatening or something that needs an intervention more than how we're explaining our symptoms. And so the same thing is true in mental health and in behavioral health. But in lieu of us having access to something like a blood pressure cuff or an O2 sat monitor, we're utilizing validated instruments. And so I want to tell just a really quick story. If you've taken this training with me before, you've heard this before, but there is this fascinating, it was written up in all of the local newspapers, but there is this guy, that's his real name, you can look it up online, Patrick Lawler, who worked as a construction worker. And so his gig in throwing up houses and buildings was putting up sheetrock, all the drywall in the house. So you can imagine that he's carrying around just kind of one of those hydraulic powered nail guns all throughout the day, and he's just throwing up sheetrock. And so in one of those instances, his power tool just kind of like knocks him in the chin, right? And so it didn't faze him more than he realized that it hit him in the chin. He carried on for the rest of the day. He went home. He had dinner with his wife. And over the next several days, he just kept complaining to his wife that he just had this nagging ache in his jaw. So that's really important. The way that Patrick was describing his pain was a nagging ache. And so as it happened, his wife worked for a dentist office, and she said, all right, I've just kind of heard about this long enough. Just come to the office. Let's take a quick look. If the dentist heard that it was a nagging ache, and he looked, and he did look in Patrick's mouth and saw no evidence of any trauma to his teeth, to his gums, nothing that was visible, he may have been inclined to just leave it there. But he had access to an empirical instrument, an X-ray machine, that he went ahead and took advantage of. And what he found is that what Patrick experienced as the power tool hitting him in the chin was actually a nail that fired up through the roof of his mouth and had almost penetrated into his brain. And so the reason that I tell this story is that when clients describe to us what their presenting issue is, what their chief complaint is, absent a validated tool, we could be missing vital information on what would be most therapeutically critical and important for us to address within their episode of care with us. So when we are utilizing these tools, they're not only to be used for diagnostic purposes, we're going to talk just a little bit about that, but also to ensure that what treatment we're providing is actually making a difference. And so if we stick with that physical health picture, if I go in, I have high blood pressure, my doctor prescribes me, maybe it's diet and exercise that we try to lower my blood pressure. Maybe I'm unwilling to try that, right? So we kind of talk about motivational interviewing. Diet and exercise just isn't really something that I'm interested in. And so my doctor goes, well, we could give you some medication to address this. If I go back into my doctor to see if the treatment is working, it only makes sense if he utilizes the same tool that we understood that I had high blood pressure to begin with. He's not simply just going to ask me, how does your blood pressure feel? Right? That doesn't make sense. Nor would it be responsible of him to say, blood pressure medication has been shown to be effective in the same way that CBT techniques have been shown to be effective. Therefore, I'm just going to believe that after 3 months, we've effectively or adequately addressed your issue. And so that really brings us to the definition of measurement-based care, which is the systematic administration of symptom rating scales and other assessment tools to guide treatment. If we only provide these tools to get measurement and we don't use them to guide treatment, we are not doing measurement-based care. And everything that I share in the following slides is no longer relevant. It just becomes moot. So the only way that we can get the effectiveness, the efficiency, and all the benefits of this evidence-based practice is when we adhere to this definition. So let's talk about what measurement-based care is. It's in 4 phases, very simple steps. One is we want to get an initial assessment or a baseline. Ideally, that's done at the time that we complete a comprehensive needs or clinical assessment. From there, there's routine collection, and that's a very broad definition, and that's on purpose. In some instances, we would be taking these assessment tools and rescoring them every time an individual comes back for session. In other times, it might be on a monthly cadence. It could be on a quarterly cadence. That's where we start getting into some really person-specific decisions on what is most appropriate, maybe per the tool or what the individual is being seen for. So I am starting to hear that feedback again. So unless you have a question, if you could keep yourself muted. If you do have a question, please interrupt and ask. After we do the routine collection, it's critical that we review, share, and discuss what it is we're seeing on these validated instruments. And we'll talk about what those instruments are in just a moment. So we'll talk about that collaboratively with our client. Think about blood pressure, right? That's not a secret. My doctor's going to share that with me. He's going to say, it's still up in the 150s. Your diet and exercise isn't cutting it. We've got to add a prescription med, or the med doesn't seem to be working. Are you taking it as prescribed? Tell me what else is going on that might be contributing. So we're having a dialogue about how treatment needs to be adjusted, right? And then the 4th is really where the magic happens. When we use the score that we're getting back to adapt how we're providing treatment, that's where the effectiveness comes in. That's where the efficiency in getting people better faster happens. We can't simply look at the score say, my client doesn't seem to be improving with depressive symptoms or anxiety symptoms, we're going to just keep trying what we've been doing and see if something different is going, some different outcome is going to happen. So when I'm talking about standardized measures or these symptoms or functional assessments, some of the most common, all of these are already available in the EHRs that you use, are the PHQ-9 for depression, the GAD-7 for anxiety, the PCL-5 for trauma. Those are our top 3 assessments used across the company. We've got lots of data around these. We also have more than what's listed on the screen, and I'll talk about where you can find those in a moment. But we have an obsessive compulsive inventory screening. So now we're getting into more, this is person specific. Every one of my clients is not going to need an OCIR. Not every single one of my clients will it be appropriate for me to do a level of functioning DLA-20 screening with. But if I'm providing skills-based services, maybe community support team or MHSS, now the DLA-20 becomes a very appropriate, calibrated tool to see whether or not the services we're providing are effective. So we have available for any of you a curated collection of approved, validated assessment tools. I'm going to just show this really quickly. I know that it's small, but I want you to know that this resource exists. And so all of these have been identified across all of our partners over the years. And the Institute, one of the things that we do is we go look at those tools and we say, are they ones that we are allowed to reproduce in our EHR environment? Do they have research backing that they're reliable and valid, which just simply means that we can trust that the outcome of that score is one that should be repeated and to guide treatment? And then we have a little legend over here and we go, is this available in Credible Behavioral Health? For what partners has that been turned on for? And the reason that I want you to know that this library exists is we could build 30 different screening tools and overwhelm the list of things that are available for you. What we want to do is we want for you all to identify, I really want and intend to use a particular instrument. Ask the Institute for us to build that out for you. And we would be happy to do that with an accompanying administration guide. And these are built out through our clinical council. So I can't spend a lot of time there, but I just want to let you know that we have these types of resources to help you implement these types of tools and for us to add additional ones as you all have some interest in expanding our library and our electronic health records. So even before we kind of drill in, I want to make sure that everybody kind of has that conceptual picture of how do I do this within my EHR environment. Within Credible, you're looking for any intake and assessment program. So the naming convention for that might look different between Grace Harbor and National Counseling Group. And then all of our validated instruments are prefixed with this MBC. So whenever you're looking at your service list dropdown, you're looking for, you can actually shortcut just by typing on your computer MBC, and you'll be brought down to the list of available assessment tools. Again, if you don't see what you're looking for, that's when I would invite you to reach out to me or Debbie and say, I'm really wanting one, let's say for personality disorder assessment. I'd really like to add that. And we can work on getting that added for the organization. Within Case Handler, you're going to find it in 2 different places. So first on the homepage, there's an indicator of when a measurement-based care tool or an assessment is due again for the individual. So we've set some rules around that with Carolina Outreach. Right now, I'm proud to say that they have successfully implemented the use of measurement-based care in their outpatient program. So we're super excited about that. This is a test client. So nobody is grossly out of compliance there, but that can be found under the therapy tab and under screenings. So hopefully that's just orienting you to where you can find this as you try to put this into use after this training. And so I've mentioned this already, but it bears repeating that measurement-based care, one, has been around for a very long time in our industry, and it's considered to be an evidence-based practice. And so it's not just an evidence-based tool. I typically will use the word a validated instrument, which means research has proven that the tool does what we think it's going to do, but that it's an evidence-based practice in that when we do the 4 steps that we identified a moment ago, that this is a clinical skill that we need to develop, that we need to practice, that we need to refine so that all of the benefits that have been proven that we'll talk about are actually ones that you're experiencing when utilizing measurement-based care. So ncgCARE, what we're aiming to do, and this happened even before 2025, CARE revised their standards. And for all accredited agencies, you must show evidence that you are in the process of implementing or have implemented measurement-based care. And so what we will be working with all of our partners on is that at the point of a comprehensive needs or clinical assessment, that regardless of maybe what that chief complaint presenting issue is, that for all adults and for all children and adolescents 11 and up, that we would do a GAD-7 and a PHQ-9. We would screen for depression and anxiety. So there's 2 reasons why we do that. One, APA, as well as really as we kind of dig into the literature, all of our industry best practices suggest that screening for those 2 symptom rating skills in particular have a lot of merit and benefit. And so 3 things really quickly. It ensures standardized, equitable care for all individuals. So now we're not potentially underserving historically marginalized populations in therapy and in behavioral health. And we're ensuring that everyone is getting screened for these 2 particular symptom sets. It's going to support data-driven treatment planning, and it really backs up our commitment to early intervention, identifying those things that if we address them, we're going to ultimately have better outcomes. So as that starts to take place at National Counseling Group, at Grace Harbor actually is utilizing both of these for value-based contracts right now with Peachtree Funder. That's what you're going to see us asking to be completed consistently for all individuals. So let's talk briefly about why across the continuum, measurement-based care is a good idea. At a macro level, what it allows us to do is to start getting a predictive analytic, which says we have data that suggest that it takes us this long to get someone with these types of scores on a depression or anxiety tool better. And so that really helps for us to understand how many clients we can serve in one length of time. It helps us understand as we drill in, if we've got Eva providing services and Larry providing services, one's using DBT, one's using CBT, one's using solution-based focused therapy. Are we seeing differences there? And so now we can start to have data and understand what evidence-based practices that are done in conjunction with measurement-based care really creates the most optimal care trajectory for an individual. At a meso level, then we start to develop what we call service delivery models that then incorporate those evidence-based practices, and we can really help to train and provide services consistently across our network of partners that aims to get people better faster. And where I want to focus the rest of our time is at this micro level, which is how it informs our decisions as clinicians to make decisions and pivot the way that we're providing care based on whether or not an individual is showing improvement. All right, so that's where we're going to spend most of our time for the rest of this half hour that we have left. So there's a few things that the research has shown us, and one of the things that I want to point out is how recent this research is. We're looking at 2023 and 2024 data. This isn't from 10, 15 years ago, but the research has started more than 2 decades ago in behavioral health. And so what we've seen, what we know is that there is accelerated symptom improvement. And there's some really big words up here that you can absolutely try to drop in supervision or at a party. Trans-theoretical, which means it doesn't matter what modality of therapy you're using. It doesn't matter, transdiagnostic, what diagnosis you're treating, or whether it's done virtually or in office, that we're still seeing that accelerated symptom trajectory regardless of those variables. So that's good news. The rates of a positive response are several times those of individuals who receive treatment without. So they've done those double-blind studies. We have plenty of evidence that proves over and over again that when measurement-based care is used, people get better faster. In fact, it's shown that clinical or functional deterioration is cut in half. And so if our mission as an organization is to improve lives, none of us got into this field to have people suffer any longer than is absolutely necessary. And so I've got a slide coming up, but it's worth saying now, we do the best until we know better. And when we know better, we do better. And I think that this is what's compelling to me as a clinician, is that if I have a tool that can cut someone's time in suffering in half, that's a tool that I want to be able to learn how to wield really accurately. So symptom reduction, improved retention, meaning clients stay engaged with us longer in treatment, and we have greater client satisfaction. We know that those are benefits of measurement-based care. And so I want to launch our second polling question. And that is, according to recent research, what is the average number of therapy sessions that it has been shown for there to be a clinically significant improvement on the GAD-7? This is fantastic, by the way. Almost 100% of you have answered this poll question. So I just really am loving the engagement from you. So thank you so much. So we've got, looks like the leader right now is 6 sessions. I don't have a poll question for this, but just kind of do an internal pulse check on yourself. Is that your intended length of stay when you start treating someone? If you evaluate your caseload today, would you say that 6 sessions is what you're aiming for, or is an average length of stay? For those of you that answered it that way, that is what research has shown. Last year in 2024, a massive 30,000 plus individuals who were presenting with a clinically significant GAD-7 score for anxiety, the median length of stay to show clinically significant reduction, and in some cases, pure recovery, meaning they no longer had anxiety symptoms, was 6 sessions. And so really, I think that we have an opportunity to look at what our standard practice is around outpatient services and say, is that true for us? Are we getting people better in that length of time on average? So really well done there. All right. So for those of you that are fans of motivational interviewing, what we have here is kind of our stages of change. And when clients come to us, we know from various funding sources, stepping down from various other higher level of care, they're not all starting at the same place. But what's really nice is that the scores account for that, meaning it doesn't matter if they're coming from an acute setting, from an enhanced service, stepping down to outpatient, or are engaged in any of that continuum of care. The score is their score regardless. And so what research has shown is that individuals entering treatment in that pre-contemplative stage, the I'm not yet ready to make a change, are those that are most likely to drop out. And what measurement-based care is that it's been most effective with those individuals that are not on track for a positive outcome. And so this is one of those things. It's a tool that you have in your toolbox now to say, if I have an individual that is extremely hard to engage, that's not quite ready, it seems, to do the work, measurement-based care can be that tool that helps them move through those stages of change more quickly and can be really effective as a proven benefit in a reduction in client dropout or early termination. And so I just happened to be looking at some data from North Carolina yesterday, and we saw that within our enhanced services, we had 60% of individuals that just kind of ghosted us. 60% of individuals that were receiving an enhanced service in North Carolina that just kind of gave up in the process, and we weren't able to keep contact with them. And so what this is suggesting is that using a measurement-based tool in that service delivery is going to keep them engaged with us longer. So we've talked about this a little bit. I'm going to just kind of do a flyover here. We know from research that individuals are more satisfied with treatment. And I think that the logic, the link here is probably clear at this point, that if I'm experiencing a benefit to the treatment, I'm likely going to be more happy, right? I'm feeling less anxious, I'm feeling less depressed, and so therefore I'm going to be much more satisfied with the service I'm receiving. They feel more respected, and that's only if we do steps 3 and 4 of those 4 steps we talked about, that we have to include them in talking about what we're seeing in their score, and we have to include them in collaborating on how we're going to change the way that we're providing them services. That's the only scenario in which they're feeling that engagement and that increased level of respect for what they're bringing to that therapeutic experience. It contributes to breaking down stigmas. I'm sure that it's unfortunate in this classroom setting that we can't all see each other all the time, but I bet that over 90% of us would raise our hands if we ourselves have been asked to fill out a PHQ when we've gone to the doctors. I certainly have. Social determinants of health has been baked in at every doctor's appointment or every practice that I've participated at. And a PHQ-9 is just standard practice, at least at my physical healthcare settings, to fill out every time I come in for my annual physical. For us as the clinician, it's been shown to restore joy in practice. And again, the link, if we're doing the work, if we're investing in the way that we need to invest in getting our clients the best care possible, when I can see that my clients are getting better, feeling better as a result of my providing services, and I'm able to discharge them, some within 6 sessions or at least shorter lengths of stay, that joy is just going to naturally follow. We'll have greater diagnostic accuracy, the ability and opportunity to address therapeutic misalignment. I've got a case study that I want us to talk about that will be able to look at this. And we're going to have enhanced skills, enhanced effectiveness, and that's going to allow us to be more successful and more ethical in service delivery. For us as an organization, our vision, so our mission is to improve lives, but our vision is to be the best behavioral health provider in the communities that we serve. And the way that we do that is to be able to demonstrate, to prove that individuals are improving. And so we are already collecting that data. We're able to see how we're doing and compare ourselves to what industry benchmarks are. We want to be an organization that promotes that we are relentlessly invested in using evidence-based practices that have these types of results, and that you are working for an organization that wants nothing less than making people better faster. And that's what this is going to bring. Okay, so the paradox. If it's been proven for over 20 years in research, why then are so few of us using measurement-based care? And so as of 2023, the statistic is less than 20%. We expect for that number to go much higher, with CARF now requiring it of accredited behavioral health organizations, but that's generally not going to be relevant to private providers, right? Those are practices that almost never are CARF accredited. So I've got my third and final polling question for you that I'm about to launch, and that is, what barriers are you currently seeing?
Julie, can we list more than one?
Yep. Check as many as you'd like.
Oh, it says it. Sorry.
No worries.
Julie?
Mm-hmm.
We have a few people who have not been able to see the polling when it comes up. Do you know, just right off the top of your head, why that might be?
I don't, but I can do some research and we can send some stuff out afterwards for sure.
Okay, thanks.
All right, so all the ones that we've listed are all the ones that you all are identifying with, which is not surprising to us. But what I'm seeing our charge as the organization is, how do we mitigate those? How do we remove some of those barriers so that MBC feels more approachable and something that you feel comfortable with? And I'd be happy to also share the results of these following this. We can send it out to all the participants because this is really great information. So as I pull my screen back up here, I'm not going to belabor this. I really want to talk about some cases, but this is what has been demonstrated in the research, is the concerns that you all share. And so again, my job today, I think, is to present a compelling case as to why measurement-based care is a good idea. And then as an organization, for us to be able to knock down some of these things that may be preventing you or discouraging you from diving in. One of the things that I want to make sure that I address is this worry about how the data is going to be used. The data for us is never intended to be used in a punitive way. What we want to be able to do is to kind of crack the code or find the secret sauce, right? And so if we're seeing that there's a cohort of individuals presenting with certain symptom, a sort of symptomology, and we're seeing that a modality like CBT is effectively addressing that, we want to share that across networks. And we want to say to providers everywhere, hey, this is sort of a recipe that has been proven to be really effective when you're working with this type of individual or individual presenting this way. That's our intention. We also, at a macro level, want to show payer sources that we're able to get their members better, faster. And we want to be able to push down those types of rate increases to our providers. So quite frankly, we've got some really good incentive from that perspective as well. And so the one I want to address is this belief that clients are going to have a negative reaction. That's going to lead us into a couple of things. So one is, there is this known thing, it's called phronesis, where clinicians, we believe that kind of our spidey sense, that clinical judgment that lives within us, is really more important than maybe what an objective assessment's going to show us. And so what we know to be true of that, though, is that's wishful thinking on our part. And that providers, we are less likely to identify when our clients have stagnated in treatment, or worse, when they've deteriorated in treatment. And we tend to overestimate our effectiveness. And so this is just an opportunity to have a little humble pie, right? And to say that, all right, research has shown that actually I might believe 85% of my client caseload's getting better, when actual rates is suggesting that it's maybe just 50%. In the same vein, or kind of on the reverse side, we believe that only 3% of our clients might be worsening, when actually about 10% of adults and 25% of youth are deteriorating while they're in treatment. So just another compelling reason why we should kind of grab hold of this. The one thing to make clear, though, is that measurement-based care is not designed to replace our clinical judgment. So we need to make sure that we hold our clinical judgment just under that lens, that it's not perfect and it's certainly not superior to what our symptomology scales are telling us, but it certainly should be used to augment it. And the other thing that I wanted to just touch on, and then we're going to go into our case studies, is how do individuals feel about it, right? So some of you listed that as a barrier. We don't have time. If I'm asking my clients to do this, they're going to have a negative attitude toward it. And what we've seen is that there's almost a universally positive attitude towards measurement-based care. In fact, research shows that 93% of individuals believe that it's important to monitor their treatment. And again, we just kind of put ourselves in the shoes of those individuals. If I went into the doctor and they hid my vitals from me, like, that would be really weird. It would be strange for them to not talk about if they're seeing things that are problematic, worrisome, or even that have been successes since the last time I was in for a session. And so we just need to kind of catch up to physical health and the normalcy of us having transparent visibility into how our health looks through vitals, and make that same shift and share. That's going to break down that stigma and also give individuals a voice in their treatment. So I'm calling an audible, just given on the time. I don't want to take away from our opportunity to have some discussion to look at how to use this with diagnosing. So Debbie, maybe that's something that we could potentially circle back to for another training opportunity, but I'd like to go right into some case studies. So the trifecta with measurement-based care, remember, we're not overstating or over-relying on our clinical judgment, but it is absolutely part of the three-legged stool, right? We interview, we gather information, we have our own clinical observation, our own clinical impressions that are formulating all of our approach and our treatment planning, and we're also utilizing the individual reported outcome measures. That's, with those three elements, is when we get the effectiveness and the efficiency that we've been talking about. So I want to present a case study, and then on the next slide, we're going to move into some discussion. And so this is a real case, de-identified, but Omar is an adolescent referred because he started to refuse to go to school, and dad was concerned about some behaviors. What we know through that comprehensive assessment is that mom just moved out of the home. She moved in with her new boyfriend. His son's playing video games 10 hours today, seemingly to cope with her new absence. And so the clinician asked both dad and Omar to complete the same symptom rating scale. And so this gives Omar this opportunity to report that he was feeling unhappy. He was having difficulty getting along with others, having trouble sleeping, among other issues. And the father, when he rated those same symptoms for his son, did not rate them with the same level of clinical significance that Omar had. And so what that's done is it's illuminated that misalignment. And it's allowed for dad, Omar, and the therapist to look at how those scores differed and the significance behind them. And dad, in this instance, looks at his son, tears in his eyes, and just says, I had no idea, right? So now we're giving youth a voice. we're starting to allow these symptom rating scales to really tell a story that if we're simply relying on us asking the right questions or that interview process extrapolating out that detail, it can be missed. And so that's just one of my favorite use cases of how this can be utilized, not just with youth, but within a family dynamic and setting. So I've de-identified how this data looks over time. This is being pulled from Credible, and we have 3 of these. So this is now the time for you all to take yourself off mute. And these are some of the questions that I want us to start thinking about. So when we look at this, we have the GAD-7 is the orange line. A lower score is less anxiety. A higher score is obviously a higher level of depression or anxiety. And this kind of green line is our PHQ-9. Tell me what you think is happening here with this individual. Whoop. Keep it basic. Clinical impression. How is this person doing?
Well, it looks like his GAD-7 scores increasing.
Yeah, his anxiety certainly has increased. How do we make sense of that over the course of, it looks like 6 months? How do we make sense of anxiety getting worsened throughout treatment?
It could be they're doing trauma work.
Yeah. Think about going to physical therapy, right? And it's going to hurt really bad as you rehab that knee, that shoulder, that hip, right? And we would expect that with therapy. So this doesn't mean that anything is being done improperly, but we need to take time to make sense of it. How would you engage your client in helping to make sense of and understand what we ought to do given the increase in anxiety? And we have a bit of a plateau, it looks like, with depression.
Talking about their experiences would help because I currently have a client in PT, OT, and a lot of other treatments. And even, each day they come in, they're experiencing pretty heavy exhaustion because they're going through a lot. And when they come in, they're often, listless and just wanting to fall asleep or go home.
Yeah.
As we discussed, the experience, the positives of it, I can see them changing how they view the service that they're receiving, and that changes also their symptoms and just outlook in general.
Yeah. Perfectly said.
I just want to say that this gives us clinicians as an opportunity to provide psychoeducation, kind of explain to clients what's going on with them so they don't think they're kind of going crazy. Like, give them an explanation of what's going on. Then they be like, okay, that makes sense, because I do that a lot with my clients, and they're like, well, I'm feeling this, I'm feeling that, and Well, that's the symptoms of what you've been diagnosed with. So it changes the conversation, and then they'll know, okay, so that's what's happening. It brings about awareness. So then when you move into treatment modalities, then it will make more sense to them why we're choosing that treatment.
Yes.
Help them with their symptoms.
I love that. I love especially how you're collaborating. You're bringing in that individual as an active participant in that discussion. Going back to what Karen said, does this feel true to you, right? If you're leaving here and your anxiety is through the roof, very clinically significant, what about our approach do you find is working that is contributing to increased anxiety? Do we need to shift our approach if this distress now has become something that's impacting your daily life? Let's look at another one. Same thing. First thing I want to talk about is this PHQ with the depression. What's our clinical impression about what's going on with depression for her?
Looks like, did you say the numbers in depression, as they get higher, that means the symptoms are worse, right? You're more severe.
Correct. For both of them, higher is more severe.
So it seems like their depression is getting better.
Yeah.
Well as their anxiety.
Yeah. We're seeing improvement in both. And so what might we want to interact with our client about as we look at these scores?
I think as an outpatient therapist, this will be great when we do quarterlies. Because then that's measurement based and we can talk about the progress, how we got there, where we were, where we're at now.
Yeah.
Or lack of progress or regression. Depends.
Absolutely. Do services seem to be working here? We might have some work, arguably, to do, depending on how much this is impacting the individual. It might be that we can leave depression alone, focus now, laser focus on the anxiety, and see if depression kind of stays stable, right? We can talk to our client and say, that's my plan. How does that feel? And then we can make that adjustment in treatment. Yeah.
I have a question. What is your recommendation on how often we should do these? Because I do use the PHQ-9 and the GAD-7 when I suspect to measure their severity. And if, I need to refer out to psychiatrists or PCP for medication, how often do you see that we should be using these assessments in our services that we provide?
Great question. We are recommending no less than monthly. It can be more frequent based on how that individual is being seen, how often, but for a PHQ and a GAD-7, monthly is sort of the industry best practice. And remember, the median number of sessions that we can see improvement is 6 sessions. I don't want to wait too long to score again to see if services are moving the needle in the right direction. Let's take a look at a third one, and I'm actually going to pull up Case Handler on this. So this is a GAD-7 anxiety measure. I'm going to pull this down so that we can look at this directly in the EHR. Again, this is a test client, and so they've had the audit, alcohol, drug use, GAD-7, and there's some functionality in Case Handler that I want to make sure we're taking advantage of. But what's our first clinical impression about how we've done managing this person's anxiety symptoms?
It seems to have decreased
significantly. They were up here almost at a 20, which is impacting daily life in a profound way. And now, about 6 months later, they're at a 7, which is an extremely low score and a profound difference from when we started. What we're able to drill into is for this particular date of service, and this is something that whether you're Incredible or Case Handler really makes sense, is to pull it up and say, what's contributing to your score? And so if I'm looking at someone feeling nervous, anxious, or on edge, what I'm able to do is I'm able to drill in. Do you see how the line is changing? This is how that particular symptom is shifting. So what happened here on June 12th that you were worrying at as high of a score as you could have provided for that particular question? And so not only frequency, not only collaborating with individuals, but actually that transparency to turn it around and say, you indicated this week that you are worrying about different things far higher than you had in previous week. Tell me what's going on there, right? So this is the catalyst that we can really jumpstart a session and say, this is what you're targeting, at least based on this scaling tool, that is providing you the most stress. Tell me if that's true to you. Tell me what that's looking like. And we can also look at what our plan for treatment was for that day and determine if we now need to make a shift, because this symptom rating scale is telling us, painting a picture that would suggest that we have some really important things to key in on. So I do want to leave a few minutes for questions as well. but I wanted to bring to your all's attention that we do have additional Relias courses. This first one will offer you independent learning. You can earn another CE for taking this in Relias, and it is a really well done course. I've gone through it a few times myself, and there's a lot of practical application. How do you queue up these types of conversations? And then there's these pro on the goes, which mean they're about 10 minutes to take, that specifically walk through the PHQ-9 and the GAD-7. We also have administrative guides so that you can look at what frequency, what clinical cutoffs, what types of evidence-based approaches are appropriate when I'm getting specific scores on these symptom rating scales. And I just want to encourage you that this residency program is an amazing conduit, especially through group supervision, case conceptualizations, to begin to talk about, I'm started to utilize measurement-based care. Now I need a little bit of coaching. I need to just kind of talk through with peers how I really integrate this into my practice to shape the way that I'm providing services. So at this point, I'd love to just open the floor up to any questions, comments, anybody that's had successes and want to share how you've done that. Would love this to just be an opportunity to share.
I'll share. I used the depression PHQ-9 on one of my clients a couple of weeks ago. I have been working with her, and she had some situations come up, and she was telling me her symptoms, and it looked like things had changed. And so I told her that I wanted to do this assessment so we can get a feel for her depression. And it came that she scored kind of high, and I recommended her to go see her PCP, or no, she had a psychiatrist. I asked her to talk to her psychiatrist about her symptoms and give them the PHQ-9 score that I provided, and told her that she was severely depressed and she may need medications to help with her treatment in addition to the services. So she did that and ended up getting put on an antidepressant, and it's been helping her.
That's wonderful. I love how you were sharing the results of the instrument with collaborating professionals. I think that's a really nice bridge to have that transparency across different members of the care team.
And she came back and shared with me when we followed up the next session that her psychiatrist did the same assessment and got the same score. So
yeah, there you go.
I have a question. I have a few clients that I provide faith-based therapy as well. And I had this one particular client, when I did her assessment, we did the GAD-7 and the PHQ-9, and her scores was like 3. And so it was kind of threw me off, because then my question to her was, okay, why did you come?
Yeah.
Services. And she talked about stressful things, but I just don't understand how she couldn't equate the questions that I was asking her on how she was feeling. So it was really slow.
Yeah. So Benita, you're keying in on something that is so critical with the therapeutic misalignment. I want to answer that question. It's 1 o'clock. I also want to respect those that have sessions. Okay. So the way you get your CE is after you exit here, there's a course evaluation that we would ask that you take. Once you've done that, that's through your learner profile, you'll have access to the certificate that will be printed with our ACEP information. So you guys can hang out. I don't have anywhere to go straight away, but I definitely want to address that question, Benita, and thank all of you that need to jump off. So Benita, what I see you doing with that is saying there's some therapeutic misalignment. What you're saying you're coming here for, it's not showing on this instrument. Let's talk about the answers that you gave to these questions and start to do some digging and some investigative work. Yeah. And there might be stigma there for her. There might be her lack of self-awareness, but that's probably my sense. That's where I'd want to start too, is just kind of going question by question and finding where those differences are.
Yeah. I think it was a lot of stigma and, negative myths about counseling,
Yes.
therapy. So, yeah. Thank you.
Any other questions, comments?
I have a question.
Mm-hmm.
How do you know when is the youngest age you would recommend using these assessments? And how do you know that their answers aren't based off of, like, mommy didn't give me ice cream, so I'm sad? Like, how do you know when the answers are, I don't want to say real, but
yeah.
How do you know when?
Yeah, just kind of like trustworthy examples or answers to questions. Yeah, so research calls that just valid and reliable. Debbie's put in the chat there that the GAD and the PHQ 13, I think that really there's a range there in research. 11 to 13 is kind of that age range. And I think it really dovetails with Benita's question, which is, let's talk about why you answered these questions in that particular way. So you've indicated that you feel sad or depressed on most of the days, and that's having a significant impact. What's contributing to that? And I think that it's going to be individual specific. And that's why that discussion, number 4, collaborating with the individual on what the approach is to mitigate those and to help alleviate some of that symptomology, is so critical. We can't guess. We have to understand what's driving that so we can work on starting to address those specific issues that are contributing. Our administrative guides get into age ranges, as well as what interventions are recommended with specific scores. And so all of that is available to you. It's linked in these slides, which is also linked to this training in Reliance.
Thank you, guys. This was informative.
Yeah. Thank you so much, everyone. If you do have questions, please don't hesitate to reach out to either Debbie or I.
Thank you, Karen. Thanks to everybody who attended. I think Jasmine